Good morning, everyone. Welcome to Pediatric Grand Rounds. Thank you for joining us again. Today's speaker is Dr. Eric Marvin in the Department of Neurosurgery, Assistant Professor of Pediatrics at VTC SOM and VCOM. Dr. Marvin is a graduate of Lake Erie College of Osteopathic Medicine and completed his neurosurgical residency right here at Carilion Clinic. After residency, he traveled to St. Louis University for a fellowship in cerebrovascular and skull-based neurosurgery. He returned to Virginia Tech and has been an attending physician for the last 7 years. His clinical duties include general neurosurgery, pediatric surgery, as well as neurovascular and oncology. He is also a teacher at the Virginia Tech Carilion School of Medicine, Liberty, and Virginia VCOM medical schools. Please join me in welcoming Dr. Eric Marvin.
Thanks for having me. I do have a love for pediatric neurosurgery. You guys probably know my partner, Dr. Affoley, does a vast majority of our pediatric neurosurgery, but with that being said, I love to be involved. It's her primary specialty, so most of us will kind of keep her busy with the pediatric volume here, but again, I'm pretty hands-on and certainly always available to help with some of the kids. So today we're going to talk a little bit about our worst enemy, pediatric shunts. They can be really challenging for us to figure out, and hopefully by the end of this lecture you'll kind of understand some of the dilemmas that we're dealing with. Hopefully we'll be able to discuss some of the CSF physiology, the pathology, why hydrocephalus is such a big deal, and then maybe talk about a little bit about who needs shunting, who doesn't need shunting, some of the complications associated with shunting, and then some of the pitfalls and how we work this up. So to start, CSF, we have to understand why it's important and what could potentially go wrong with CSF. We know that it's made mostly by the choroid plexus. It's made by the lateral ventricles, mostly in the lateral ventricles. There's also choroid plexus in the third ventricle, the fourth ventricle, but most of it's made on the top of the brain, which is important to understand in terms of the direction of flow. We're not going to go through like how much volume is in each pediatric per kilogram, but understanding the dynamics in an adult will help us understand the problems. We have about 500 cc's of spinal fluid in our ventricles, in our fecal sac, and our cisterns. But the important thing is that it turns over about 3 times. So we make about 150 cc's. That's our volume. It turns over 3 times. And so there's a balance that has to be maintained. We make 500 cc's. We have to absorb 500 cc's. Not entirely sure what it does, but we do know that it provides some buoyancy. We know that it makes the brain lighter. It provides a shock absorption system to the brain for trauma protection. And we think that it kind of helps dispel some of the byproducts of brain metabolism. And for us, this is an important thing to understand in terms of where the direction of the flow is. So we know it's made on the top in the lateral ventricles, goes through the foramen Monroe, then into the third ventricle. It goes through a very narrow passage called the cerebral aqueduct, and then into the fourth ventricle, into the posterior fossa. So any of those passageways are potentially a spot that could obstruct the flow and back up the flow. After it gets into the fourth ventricle, there's a couple of foramina in the fourth ventricle that allows the spinal fluid to essentially flow over the convexities of the hemispheres, and that's where it gets absorbed passively by the arachnoid granulations. It's pressure dependent, and that's basically the pathway for the spinal fluid. Why it's important, we're going to see a handful of patients every year that are born with a congenital hydrocephalus. A lot of what we see in this area are a little bit more secondary involved with brain tumors, traumas, those types of things. But we do see congenitally related hydrocephalus, and we know it's important. The prognosis is often going to depend on really what the underlying pathophysiology is. Is it a brain tumor? Is it a trauma? Or is it just hydrocephalus related to congenital anomalies? But we know if we don't get involved, then there's a pretty high mortality rate associated with a lot of these children, up to 54% mortality rate over 10 years. And what we do see is in patients that don't get shunted, but they do survive, there's a huge ding to the cognitive abilities of these children. Versus, intervening doesn't give us a 0% mortality, but it substantially decreases those that morbidity and mortality related to the hydrocephalus. And so there's basically three ways to come up with a hydrocephalus type of a picture. One is more production than the brain can handle. And we don't see that very often. That's a pretty rare phenomenon. That's pretty much limited to choroid plexus tumors. So choroid plexus papilloma, choroid plexus carcinoma. We don't really see a whole lot of pathologies that are going to be making too much spinal fluid. The two that we do get involved with a lot are either an obstructive phenomenon or an issue with decreased absorption. So, the production is remaining stable, but there's something hindering the arachnoid granulation's ability to absorb the spinal fluid. And we see that in hemorrhages, traumas, post-surgical procedures. We also see it in infections can be common. In our country, in developed countries, the biggest causes are going to be germinal matrix hemorrhages that we see in the pediatric population. Aqueductal stenosis, which is not very common, but one of the bigger common causes, of course, of kind of a congenital hydrocephalus. Myelomeningocele and then brain tumors. We do see a couple of genetics that we know are associated with hydrocephalus, mostly an X-linked L1 CAM mutation, as well as the Vectoral syndrome. So symptoms are big for us. Just because we see big ventricles, we have to take that in the clinical context of what's this doing to the baby, or what's this doing to an adult. It's more of a question with an adult because obviously, we're not going to be born with large ventricles. There's usually a source of that. Sometimes it's, in utero stroke and there's loss of brain, which is going to cause a sort of a secondary compensation with the ventricles. So sometimes we'll see large ventricles that we don't need to intervene on. But in babies, the two things we're going to be kind of separating in terms of signs and symptoms are going to be those who have closed their fontanelles and those who haven't. So for the neonates, we're going to be measuring the head circumference. In terms of intervention, a lot of this is going to be based on whether or not they're having any apneic spells, whether or not there's any bradycardic spells. Those are going to be our big signs in terms of do they need a ventricular tap or are they ready for a shunt? But we're also going to be looking at their fontanelles. The nice thing with the neonates is that we can kind of indirectly measure their pressure without putting anything in their brain. And we do that just by palpating their head. How full is their fontanelle? We also look at the suture size. So, we can, on a day-to-day or week-to-week basis, we can try to tell, are these sutures becoming more and more splayed? Did they start out at 5 millimeters and now they're at 1 centimeter? So all those things are kind of things that we're watching in terms of, does this patient do they need an intervention, and are they ready for a more definitive procedure? Or can we just, allow them to develop and see how the signs and symptoms develop as well as the imaging? After the fontanelles are closed, everything is related to pretty much intracranial pressure type of symptoms. So a lot of it's nausea, vomiting, headaches, and drowsiness. In some of our pediatric patients, we'll get a paranoid syndrome or a sunsetting eyes, which is basically a paralysis of gaze. They'll have kind of some lid retraction and a downward gaze preference. We don't see that a lot, but it's pretty syndromic of hydrocephalus in kids. Symptoms are usually going to be worse in the morning and they get better throughout the day. So a kid that has worsening headaches in the morning, that may be a part of the symptom, part of the syndrome, all related to, when the kid stands up, you have gravity that kind of forces some drainage. You probably also have a little bit of CO2 retention when the child is sleeping. So headaches are usually worse in the morning. These are kind of the things that we're going to get involved in, indications for shunting. So hydrocephalus related to either an obstruction or communicating type of hydrocephalus. Hemorrhages that, hemorrhages can cause both obstruction and communicating hydrocephalus, but ventricles that are getting bigger, head circumference that's going off the curve, symptomatic ventriculomegaly. But these are the big things that we're going to look for. Pseudotumor we don't really see in children's. NPH obviously we don't really see in children either, but we do get involved for those types of large ventricle syndromes as well. So I'll talk a little bit about some of the cases. I've tried to pull up some recent cases. They're not all mine, but these are kind of what we deal with in the hospital mostly, but of course we follow these patients outpatient too to assess for shunt function and make sure they're doing okay. This is a patient X-linked hydrocephalus, diagnosed more with a hydranencephaly. It's always hard to tell whether or not you're dealing with a hydranencephaly versus a maximal hydrocephalus. You can see there's a cortical rim around the large ventricles. So it will be interesting to see kind of over the course of a year to 2 years whether or not that cortical expansion will happen, or if this is just lack of parenchyma. But the indications here, for shunting is really head control, that size control. And you see on the growth chart at birth, kind of way off, and especially in a child that has brainstem and a little bit of cerebellum. Being able to control the trunk and be able to control the head is a big issue. So sometimes we will shunt just to control the size of the head. Here is another sort of cause of an obstructive hydrocephalus. Probably in the pediatric patient, one of the things that we see the most in terms of hydrocephalus and when we have to get involved. Of course, we have to get involved for the brain tumor itself. You see this fairly large posterior fossa, fourth ventricular tumor. The T2 shows much larger ventricles than he should have for his age, presented with nausea, vomiting, and headaches. This is my partner's. She did a gross total resection, looked great. Diagnosis was medulloblastoma. You can see the ventricles on the post-op scan. Everything came down. Way to go. We don't have to do anything further. We do put drains in most of these patients, external ventricular catheters, for 2 reasons. One is that it tends to help with the hydrocephalus, so we want to make sure they're protected. The second reason is that it helps with our wound closure. Any of our posterior fossa resections, we're operating on the bottom part of the brain, so we sit that patient up, and that water is going to love to drain out of our repairs. So if we can drain spinal fluid off the ventricles, that'll help take the pressure off the wound, and it really will help prevent spinal leaks in a delayed fashion. Our algorithm is a little different for everybody, but essentially once we have that EVD in, we'll usually drain them pretty, what I'll call hard for the first 2 to 3 days, which is, we'll leave it open at 0, we'll leave it open at 5 centimeters of water. We're really encouraging that spinal fluid to come down. And then after those 2 to 3 days, we'll clamp the EVD, or we'll start raising it slowly. And eventually we'll clamp it, we'll monitor the pressures, we'll monitor the neurological signs, we'll get a post image, either an MRI or a CT, and if appropriate, we'll take the EVD out. And this patient, unfortunately, was not a patient that could do that. Some of these patients are essentially hostage until we get the EVD out of their head. So after failing 2 trials, most of us will say, all right, you've been in the ICU for 10 days. This patient has declared themselves. You can see the large ventricles that happen after we clamp the EVD. So this patient went on to receive a shunt, which is appropriate. You can see kind of the post-shunt MRI, which looks good. Here's a patient that I did a couple of months ago. Sort of similar pictures. Turned out to be a grade 3 ependymoma. You can see the large ventricles that the patient presented with. Gross total resection. Same sort of issues. Clamp the EVD, ICPs go up, drain them hard for another couple days, clamp it, ICPs stayed normal. Unfortunately, he was leaking spinal fluid out the drain site, so it became a little bit hard to figure out, is there an increased pressure phenomenon, or is the spinal fluid just finding a way out of the skull? And so for this one, we pulled the EVD and watched the patient very closely, got a couple of pictures before the patient was discharged, followed him neurologically, and so, we got away with this. And I would say most of our patients, we can get these EVDs out without any problems, but we are prepared to intervene if we need to. Some of the more complicated and frustrating things that we deal with are in the settings of infections. So this is a very sweet 13-year-old. She had a shunt placed at birth for germinal matrix hemorrhage. She had one revision a few years later and then was kind of lost for about 8 years. She presented with seizures. Since then, she presents very consistently with a very specific syndrome, and I think that's what's, that's sort of the takeaway, is that every child will have, when they go into shunt failure, a pretty specific syndrome to them, and it's not 100% consistent, but the family is usually pretty right when they say, oh, this is how she presents when she's in failure. So she presents with headache, nausea, and really bad photophobia. And you can see all of the interventions that we've had to perform on this sweet child in, just the last 8 months. And you can see all of us have been involved. Most of this has been proximal catheter related, but what ends up happening is, she eventually gets diagnosed with a CSF infection. Of course, it's an indolent infection, so the gram stains don't actually come back for a week after we've done the revision. And she's been in the hospital at least twice now with EVDs, trying to get her system clean. I've done her last surgery, which was a big surgery for her. I'll show you kind of some of these x-rays. During one of the surgeries, one of my partners tried removing a catheter, and we have tricks and techniques to remove the catheter, but sometimes they don't come out, especially if it's been in there for 15 years or 10 years. So she had a break in her catheter, but she kept coming back with this same indolent infection. So during the last surgery, you can see we fished out one of the catheters that had been retained. We got a nice looking catheter, but afterwards, you can see she's got a lot of pneumocephalus in her post-op scan. But this is kind of her MRI when she presents. So the nice thing about her is that her ventricles blow up when she's in failure. Her symptoms are very, very characteristic for her. But when you're dealing with shunt infections, they can be super tricky to kind of take care of. Another infection that we've been dealing with the last couple of months, kid with Bacterial, actually came back from some esophageal procedures and went into shunt failure. His CSF came back with fungal ventriculitis, and these can be super hard for us to deal with. So he's underwent several surgeries, several revisions. His big problem, in addition to the infection, is that some of these fungal infections will kind of loculate the ventricular system. So you now have a lot of ventricles that are not communicating with each other. At one point, I tried to do an endoscopic fenestration, but the anatomy was so bad, you can't just start fenestrating things that you don't know where you're at in the brain. So that failed. What he has in right now seems to be working. He's got 3 separate ventricles that dilate. You can see he had pus in his ventricles at one point. You can see the diffusion restriction in the temporal horn. So he's got a large cyst in the temporal horn that dilates, and the left and the right don't communicate. So he's got one catheter in the temporal horn, and then he's got one catheter that goes from the left to the right through the septum. And we put that one in about 3 months ago, and he came in with a failure. And he's just had another revision. Same catheter placement seems to be working now, but some of these indolent infections, even the fungal infections, can be super hard to get them to a sort of a static, doing well type of a state. Another type of thing that we can, this is, again, more on the lines of an obstructive type of phenomenon. This patient was referred to the hospital for a Chiari malformation, 16-year-old. Impressive Chiari, but I think when we see these MRIs, the first thing we kind of look at is, obviously a lot of people are going to be born with a Chiari malformation. We see them in adults. They're a dime a dozen. But you always want to make sure, are they a congenital Chiari or are they acquired Chiari? And you can kind of see from this picture the large ventricles, the big third ventricle, and you'd have to see all the MRIs, but is there actually some stenosis of the aqueduct here? And so this was a little bit more of an acquired Chiari. If you kind of look through the MRIs a little bit, you see the large ventricles, the beginning of some what we call transependymal flow, and she's also got this sort of T2 flare signal in the brainstem. So for somebody like this, I think shunting is very reasonable. She's got hydrocephalus. She has really bad headaches. Sticking a catheter in there is an absolute appropriate treatment. The other thing that we do have to work with, though, is what's called an endoscopic third ventriculostomy, where we can go down to the bottom of the third ventricle, we can pop a hole in it, and basically communicate the third ventricle with the cisternal spaces, and so that can happen. You know, there's a little bit of discrepancy in terms of who wants to do it, who should do it, when it's indicated. But for aqueductal stenosis, it's a great procedure because you don't have a bunch of hardware that we have to put in. The bad thing is that when the ETV fails, it's a little hard to diagnose. There's no reservoir to tap. We're basically going on imaging and symptoms. So there's a plus minus with the procedure. There are a lot of surgical nuances that we have to account for before we even consider it. Certainly, complications can be devastating if not done correctly. But, you know, she ended up getting a biopsy. It was kind of what we think it is, low-grade glioma. I think her ETV was successful, and kind of her post-op pictures, I think, are pretty convincing. You can see all of her ventricles have come down. The Chiari is still present, but perhaps a little less impressive. Ventricle sizes is down. Our CSF MRIs show good patency through the ETV. So good person to not have to put a bunch of stuff in that potentially could get infected. So I wanted to switch this up a little bit here. It's been a while since we've seen a myelomeningocele. So if you guys haven't seen one for a while, this is kind of what they look like when they're born. First thing that we're going to do for a myelo patient is close the myelomeningocele. High risk of these things getting infected. I was pulling this patient up for a different reason, but I actually saw that we took some pictures, so I thought that would be interesting. This is sort of identifying the placode. This is identifying our muscular layer that we're going to close the placode over. There's a fascial layer that we close, and then, you know, we close the skin up. There are a lot of intracranial associations that we see with Chiari2s and myelomeningoceles. And these are kind of some things to kind of look at when you see an MRI on a Chiari2 patient. There's a lot of classic things that we see. For a neurosurgeon, there's kind of two big things that we're going to be looking at. One is the Chiari and what's going on with the posterior fossa. Is there a lot of compression? Is there a large syrinx? Is there brainstem compression? And then the other thing is hydrocephalus. And we know that these patients have a very large percentage of hydrocephalus. And a lot of them, when they're born, may not demonstrate hydrocephalus right away, but as soon as we close that myelomeningocele, then the ventricles start building up with spinal fluid. You guys probably know about the MOMS trial, which I don't know what the pediatric neurosurgery world is doing now, but there was a pretty significant decrease in hydrocephalus for intrauterine closure. So something to think about. I don't believe we offer that here at this hospital, but when they're born, that's their first thing is we're thinking about, you know, does this patient need a shunt? That's always on and there's not a lot of patients that will get by without it, but we watch them very closely. We watch their head circumference, we watch their clinical development, and we watch their imaging. And occasionally, you know, and the literature is definitely supporting more of a less aggressive shunt first, ask questions later type of an approach. So, but for this patient, hydrocephalus continued to get better, continued to get worse. Symptomatically, the baby looked great, but month after month after month, the head circumferences was going off the charts. The ventricles were getting bigger, and so, you know, I told Mom, you know, your child has to have a shunt, and she was very adamant about not having a shunt. There's been a little bit of research about shunting myelomeningocele or ETVs on myelomeningocele. So we thought, well, you know, it's a procedure, risk benefit. This is kind of what our ETVs look like. So this is a look at from our endoscope. This is the bottom of the third ventricle. It's a little abnormal appearing because of the hydrocephalus, but you can see your mammillary bodies. You can see your infundibular recess, and we poke a hole in the bottom here, and that allows that spinal fluid to get through. If you kind of go back and look at the pre-op MRI, if we kind of did a fine cut T2 sagittal, you'll see that potentially a big part of this baby's problem is the aqueductal stenosis. So I don't think this was an unindicated procedure, but there's not a lot of great data to support ETVs for Chiari-2 patients. This bottom picture is kind of a look with a flexible scope going around the ventricular wall down into the actual temporal horn. And so with this baby, what we did also is called a choroid plexus cauterization. So we know the spinal fluid is being made by the choroid plexus. We burn it. And there's some more data that's coming out there showing that it's a relevant procedure. When it was done back in the 70s and 80s, the morbidity of these procedures were so high that we kind of abandoned them. With the flexible endoscopes, it allows us to kind of travel around the ventricle system, without hurting anything. So as of right now, baby's doing great. You can see a patency of the ETV. The ventricles look like they've come down a little bit. So pre-op's on the left, post-op's on the right. You can see the lateral ventricles are definitely down. The third ventricle is definitely down. See that the large massive intermediate is even more apparent. But again, this is a patient that we have to continue to follow really closely with head circumference and imaging. I think, what do we think about when we see the shunt? The shunt, it can bring us to our knees. It's what we call a bread and butter procedure. It's something that, the junior residents are trained on early. It's one of our key sort of measures in terms of, competence with neurosurgery residents. But we got to know the catheter, we got to know the system very well. So it's a pretty simple system. There's a proximal catheter that goes into the brain. There's a distal catheter that goes somewhere, usually into the belly. And then there's some sort of valve associated with it. The valves will open at a specific pressure. And we have fixed pressure valves. A lot of us are now putting in programmable valves, which allows us to kind of tweak when the valve is going to open, which can be very helpful, but it can also be very frustrating. This is kind of what we do when somebody calls us in the emergency department and they say, hey, we got a baby with a shunt. So we start pulling up all our references. What kind of shunt do they have? What type of valve do they have? What is the setting? Most of the valve, the adjustable valves are now supposed to be MRI compatible, but being around a strong magnet may change the setting. So we're always looking at this. These are the tools that we can use to check the settings, but a lot of us will check an X-ray. We'll often get a shunt film, and that'll give us the setting of the setting of the valve. Anyways, this is a strata valve. I don't use a lot of these anymore, but this is kind of what we're doing when we're putting pressures. So, if we set the strata valve at 2.5, it'll open up somewhere between 20 and 22. So that's pretty high for a pediatric. A little high normal for an adult. So 2.5 is a pretty high setting, as opposed to, if we set it at 0.5, the valve's going to open up somewhere between 1.5 and 3.5, really low pressure. So we do have to be a little careful with how aggressive we're programming these valves. In terms of shunt failure, so probably the biggest risk of a shunt failure is the placement of a shunt. So there's a high complication rate, not at Carilion, just throughout the entire country. Most of the time, what we're going to see is a proximal obstruction. There's been a lot of literature trying to figure out where that obstruction is coming from. I'd say most people think that it's the choroid plexus. These catheter tips have very fine holes, and as the choroid plexus is floating in spinal fluid, it's a very mobile kind of structure. There were some studies that were done taking the catheters out and then looking at them under a microscope. And there is a lot of choroid plexus debris that gets filled, but there's also protein, there's also gliotic scar tissue. I believe it was in the 60s, somebody came up with a cage. They have basically a wire cage around the catheter to prevent things from getting into the holes, which were great. The holes stayed patent, the catheter did well. When they stopped working, they were impossible to get these things out of the brain. So, like of all of our inventions that we've done, we haven't made a whole lot of progress in trying to decrease our shunt failure rates. Behind proximal obstruction, infection remains a big problem. And then distal obstructions, don't see quite as often. They tend to occur longer out. So the longer the patient goes in presentation of shunt failure, the higher the chance it's going to be a distal obstruction. occasionally we'll see a fulminant infection with pus coming out, but most of the time these are indolent infections. You can see with the last baby that I presented, some of the problems are they're so indolent. I did one procedure on her, and we waited for 45 minutes to get a stat gram stain, came back negative, put a new shunt system in, and then 5 days later it comes back as another indolent infection, and now we put a complete new system in an infected in an infected cavity. So that can be a big problem. They're very hard to treat. Talked a little bit about the obstruction. We do see some disconnections. It's not super common. Catheters can break, especially the ones that have been in there for a long time. If you've ever seen a revision, these things become very friable. Often when we try to remove the catheters, especially the belly part, they'll just break off in the belly. We do see it. Sometimes babies outgrow their shunts and the catheter will start migrating. We also have to be a little careful, especially with the adjustable valves, that we don't over-shunt our kids. So here's an example of a 15-year-old came in, polycytic astrocytoma, and his problem after surgery is we could not get his ventricle size looking normal. So we drained him at 10, and then we drained him at 5, and ultimately ended up draining him at negative atmospheric pressure. And so, we ended up putting a shunt system in him with no valve, basically just a siphon device. You can imagine it's probably not a huge deal if a person's lying flat, but when they get up and they start walking around, that's a lot of spinal fluid that's going to drain. He went to rehab, came back, and sort of had a CT suggesting overdrainage. He presented with one seizure and progressive hearing loss. You can kind of see the very small slit ventricles, the subdural hygroma, and then the MRI is kind of a classic pachymeningeal enhancement. Putting in a valve helped this guy out pretty significantly. So in terms of what do we do? You know what I mean? A baby comes into the hospital and they have a headache and they have a shunt. I think, there are some babies that are very easy. There are some children that are very straightforward. Nobody's very easy, but a lot of them can be more straightforward than others. So number one, have they had a failure before? And what does that failure look like? What is their clinical signs of increased intracranial pressure? Is it headache? Is it nausea? Is it photophobia? Is it seizures? And then more importantly, what is their imaging doing? When they're in shunt failure, do their ventricles get larger? And I would say for 80% of our children, that's what happens. A kid starts presenting with headaches. We get an MRI or a CT scan. The ventricles are getting bigger. I don't want to say nothing in this world is a slam dunk, but it makes a lot of sense to us. But shunts can be kind of a magical box, so we have to be a little careful with that as well. But these are the things that we're going to kind of look for. What were their symptoms? What are the imaging findings? When was their last revision? We have a lot of peds that come in with a shunt, and they come in with belly pain. Were they around sick people? Do they have GI issues? What we have found is maybe one of the most sensitive and reliable indicators is, what does mom say? Does mom say the baby's in shunt failure? Pretty often she's going to be correct. She knows their child better than any of us, so if she's suspicious, we're suspicious. I think one of the things that we should kind of talk about is imaging, and we'll get a lot of MRIs for surveillance and baseline imaging, maybe a slow indolent failure, but if a patient comes to the hospital with headaches, we're not going to wait for an MRI. These patients can potentially die, if we don't get to them quickly. So CAT scan is mandatory. Sometimes we'll order shunt series. They often go hand in hand. It helps us identify the setting on the valve, but it also makes sure that there isn't any breaks. In large adults, sometimes in large children, we have to worry about intra-abdominal pressure. We've seen abdominal catheters kind of expulse themselves out of the belly, so we got to make sure that the catheter hasn't moved. And then definitely, I think, in patients that haven't had a shunt revision for years, but we're highly suspicious, some sort of picture of the abdomen can be helpful. Because again, the longer they get out from their last revision, the higher that we're worried about distal failure. So we want to look for a pseudocyst at the end of the catheter tip. So here's a non-pediatric patient, but this is again kind of something that we have to deal with. Myelomeningocele, KRE2, shunted at birth. The only previous CAT scan I had was in 2009. She came back in 2019 with this. kind of worrisome, huge ventricles, where we know they were small before, maybe even over shunted before. We get a shunt series, and here's that catheter break. They do tend to happen over the collarbone a lot. And so what do you do with this? Do we rush this patient to the hospital? Do we interrogate it? And for her, there's a lot of things that we try to do to figure out, is this a compensated hydrocephalus or is this a true shunt failure? Sometimes we'll get ophthalmology involved, we'll look for papilledema. There's some nuclear studies that we can inject the catheter, inject the reservoir, and see where the fluid goes. But CAT scan or MRI has been stable for the last 3 years now. So she was in a state of compensated hydrocephalus. And what we do know is that if we intervene on this, usually bad things will happen. So we don't ever want to drain somebody that is not symptomatic. So these are the questions that we're going to ask kind of pretty specifically in the ER. This is what we're going to talk to the family about. When was the shunt placed? Why was it placed? Has there ever been any revisions? And tell us about that. What are the current symptoms, and were these symptoms, have they had these symptoms before? Again, looking at the GI stuff, if they've had the failures in the past, what are the symptoms like? Knowing what it is an amazing help if we have baseline scans and we have failure scans. But when we don't, they can be very, very problematic to figure out. And one of the biggest problems is about 15% of the kids, maybe 20% of kids will present with shunt failure with a normal, with a CT that looks like their normal baseline CT, or MRI. So we have to have a high degree of suspicion for these children. We talked a little bit about the X-rays and the CTs and the ultrasounds. And then we get to the point of, all right, we have this system that we put in that we can actually get some diagnostic information from. Number one is the reservoir. So the reservoir is usually very depressible and refills very quickly. In a patient that is working and well, the reservoir is located proximal to the valve. So it gives us access to the spinal fluid without having to go through the valve. So we depress it, it should refill very, very briskly. If we depress it and it doesn't refill, it's a data indicator. It's another data point, but it doesn't give us the definitive answer. And then, whether or not we should tap the shunt. So the reservoir also gives us access to that catheter system, and we can stick a needle in it and get more information. So usually, I was trained as a resident, don't ever stick a needle in that reservoir. It can infect it. There's been a couple of good papers that's come out in the last probably 5 to 7 years saying, if you tap it correctly, the risk of shunt infection is almost zero. So we've kind of been a little bit more aggressive with tapping the shunts, especially when the picture is a little equivocal. But if the symptoms, suggest hydrocephalus, but the imaging is so-so, or if the symptoms are really severe, the patient's in a coma, it's still going to take us an hour to get them to the OR, get them prepped, get everything ready. We can tap it and temporarily alleviate some of the pressure. Certainly if there's a question of an infection, we may want to tap it, sit on it for an hour, get a gram stain, make sure it's not actively infected before we decide to either put in a new system or put in an EVD. And then in those kids that have had shunt failures but their ventricles don't blow up, those are all good reasons to tap the shunt. And basically, if you look at the literature, it'll say, well, you stick a needle in it, you hook it to a manometer. We use a 35 centimeter butterfly needle. And if you hold it up, it's going to tell you exactly what your manometer pressure is. So it's very easy to do. You stick it in there, you look for spontaneous flow, and you look for the pressure. If the pressure is high, that gives us our answer. If the pressure is low, it doesn't help us out a whole lot, but it's another data point. If we can't get anything out of there, we'll gently aspirate, and then, we'll get the pressure, and then we'll allow it to flow through the valve. Hopefully we'll be able to tease out a distal versus a proximal failure. But, in the end, sometimes you're looking at, the reservoir doesn't depress, we don't get spontaneous flow, but it aspirates pretty easily. The patient looks really bad, they got horrible headaches, they're nausea, they're vomiting. CT, the ventricles may look a little bigger, but it could be the gantry. So in the end, it's the surgeon's decision, and we have to balance that risk of shunt infections and complications with going back in versus the complication of not doing anything. And so sometimes there's a judgment call that's involved in this as well. So, what are we doing to kind of help minimize our complications? What is the field of pediatric neurosurgery doing to push the needle? When I did my fellowship, they had a separate Peds hospital, and their surgeons there did a couple of things that I thought was interesting, one of which I've adopted. One is endoscopic placement. The literature is pretty clear. It's nice to put them in and know where you're at. Like, you can see the ventricle, you can see exactly where you're putting the catheter, but the literature is pretty clear that it doesn't improve, our failure rates. The other thing is the stereotactic navigation. Again, literature is pretty clear that it hasn't improved, but I tell you what, just anecdotally, shunts can be hard enough to manage just, at face value, but when you put a catheter in a baby that has large ventricles and you say, oh, I can't miss that ventricle, there's no way, that ventricle is huge. And you get a post-op scan and the catheter does not go where you want, it does not make you feel very good. And I think stereotactic navigation has improved our need to take the baby back to put the catheter back in the right spot. So I think that for our institution has been a pretty big game changer. And then, all these other things that have been designed have really not helped a whole lot. We've got some flow valves, we've got some gravitational valves, we have anti-siphon devices. The adjustable valves haven't decreased in lower morbidity, return to OR, failure rates. The antibiotic-coated catheters may have helped a little bit with some of the infections, but we're still dealing with a lot of kids will undergo a shunt revision, and then 6 weeks down the road we'll undergo another revision. And so, again, I think the proximal catheter obstruction is always the biggest thing on our thought process. Is it plugged? The valve, I haven't seen a whole lot of valves cause failures, but we usually replace them out when we're in there, give them a new system. And then, the belly part, we'll often get, I think we all feel pretty comfortable going in the belly, but anytime things get complex, we get our general surgery, our Peds general surgery involved. That's actually been a new implementation now. I think all of our pediatric surgery is going to be done with the pediatric general surgery team. I don't know necessarily if this is going to improve, failure rates or shunt infections or anything like that, but it certainly makes things more comprehensive and smooth for the kids, so it seems reasonable. Infections, we have to have a super high suspicion, especially in the first month and definitely in the first 6 months. So, when a kid fails after an immediate shunt revision, that's one of the first things we're thinking about is it infected? And that becomes hard for us to navigate because, as a surgeon, you say, well, you got this whole contaminated system in the brain. We have to remove the whole thing. We have to put an EVD in. We have to wait for the spinal fluid to be clean before we put a new system in. And that's really hard for the children, and it's really hard for the families as well because, they're locked up in the ICU for a week to 10 days to 2 weeks. Shunt fractures, we don't see a whole lot, but again, we always have that question of, do they actually need the shunt? Are they doing okay and we just found it on accident, or did it fracture and now it's causing problems? The other thing I am not going to spend a lot of time on because it's really hard to talk about because nobody really understands it, but this syndrome of slit ventricle syndrome, which is basically it's a low compliance type of a syndrome in the brain. And that's where we end up with these babies that have very small ventricles and they can end up with a failure, and you don't see that on the CT scan. And so what we think in slit ventricle syndrome is, because the compliance is so poor, and in a general pediatric patient, 1 cc of volume is going to cause a percentage increase in ICP. In a person with low compliance, that same increase in volume may cause a drastic increase in pressure. I should have put a pressure volume curve up here. But these kids can die with very small changes in their shunt system. So they're super challenging. It's really hard to find a valve that works for them. Their workup and treatment often involves an EVD with kind of tweaking of the pressures, lots of scans, and lots of neurological exams. But, again, when we have a baby that has low compliance, they take a little bit of time to kind of figure out. So, bread and butter procedure, but again, they can bring you to your knees. Does anybody have any questions?